I'd like to present the journal club for today. It is the multicap collaborative multicap study that it goes by the title the combined use of a multiplex PCR and serum procalcitonin to reduce antibiotic exposure in critically ill patients with community acquired pneumonia, which is the multicap RCT. It was done by the Multicap Collaborative Trial Group of Investigators in France. It was published on 15th of July 2025 in the Intensive Care Medicine Journal. Now, community-acquired pneumonia is one of the leading causes of ICU admission and in-hospital mortality. However, if there is inadequate or overtly broad antibiotic therapy coverage for community-acquired pneumonia in ICU, it can be associated with poor outcomes in sepsis and it can promote bacterial resistance. So, it is extremely needed that there should be strategies which incorporate adequate and narrow-spectrum antimicrobial therapy into the treatment modalities for community-acquired pneumonia. Now, the ESICM 2023 guidelines for community-acquired pneumonia suggest the use of procalcitonin to reduce the duration of antibiotic treatment in patients with severe community-acquired pneumonia. It's a conditional recommendation with a low quality of evidence. ESICM 2023 also suggests for the use of multiplex PCR for detection of the bacteria as well as the bacterial resistance genes if non-cap antibiotics are going to be used for the treatment. However, they have not made any such recommendations when general antibiotics are to be used for community-acquired pneumonia. Now, broad-spectrum multiplex PCR tests can be accurately detect a large panel of respiratory microorganisms, including bacteria, viruses, as well as some bacterial resistance genes within a short turnaround time, which gives us a huge advantage. Now, coming to the advantages of multiplex PCR, especially in community-acquired pneumonia, it can facilitate antibiotic de-escalation from empiric to a targeted therapy in a very short time, and it can increase the proportion of patients receiving appropriate antibiotic therapy. And in case the community-acquired pneumonia is because of pure viral etiology and the patient has a low PCT, in such patients, antibiotics can be stopped early in a definitive manner. However, there is a lack of clinical evidence of its beneficial impact in community-acquired pneumonia. Previously, only one study has been done which has combined the use of procalcitonin and broad panel multiplex PCR and has to guide the antibiotic use for respiratory infections in hospitalized adults. This RCT was published in the Journal of Infectious Disease in 2015. It was a single-centered study, which was and it was open label. They had recruited 300 patients hospitalized with LRTI, in which in the intervention group, they had done multiplex PCR and procalcitonin-based antibiotic de-escalation, while in the control group, there was usual care was given. Even procalcitonin was also not used. Coming to the outcome, there was no difference in the total duration of antibiotic therapy. However, its biggest limitation was that there was low adherence to the antibiotic de-escalation algorithm. Only 30%, only in 31% of the patients, there was adherence to whatever de-escalation was supposed to be done. So, because of such low adherence, the outcome, the study outcome cannot be trusted. Moreover, they also saw in this that whenever the procalcitonin was low, or in respiratory MPCR, if only viruses were detected, there was less adherence to the de-escalation. Means the physicians were hesitant to de-escalate antibiotics when PCT was low, and only when virus was detected in the MPCR. Now, coming to the rationale of the study, since no RCT has investigated the beneficial effect of combined use of MPCR and PCT on antibiotic de-escalation is CAP with good adherence to a predefined algorithm. So, this study needs to be done. So, coming to its hypothesis, in adults admitted to the ICU for severe community-acquired pneumonia, a diagnostic and therapeutic management strategy combining a broad panel respiratory multiplex PCR and an algorithm of early antibiotic de-escalation or discontinuation should be associated with a higher clinical efficacy and safety and a lower overall cost of hospital care as compared to a conventional management strategy. So this trial was designed as a multi-centered, parallel group, open-labeled, randomized controlled trial. It was conducted in adult patient with community-acquired pneumonia admitted to the ICU of 20. So in this, coming to the study sites, about 20 ICUs of university-affiliated hospitals in France were selected, in which such adult patients with community-acquired pneumonia were recruited. The study duration was from October 4, 2018 to 3rd of March 2022. However, it was stopped for a brief period of 2 months from March of 2020 to May of 2020 because of COVID. Other than that, the recruitment was uniform. It was registered at NCT and UDRA-CT before initiation. It was the funding, coming to the funding, it was funded by the French Ministry of Health and Biometrics. French Ministry of Health and Biometrics. The adult patients with community-acquired pneumonia admitted to ICU in 20 ICUs of university-affiliated hospitals in France were included. Coming to the inclusion criteria, adult patients more than 18 years of age with CAP who were admitted to the ICU within 18 hours or less were included. The pneumonia was called community-acquired pneumonia if the time interval between the hospital admission and the ICU referral was less than 48 hours, and after taking informed consent, these patients were included. Now, for diagnosis of pneumonia, 2 out of the following criteria had to be fulfilled: a temperature of 37.8 degrees, heart rate, tachypnea, respiratory rate of more than 25, chest pain, cough, expectoration, localized crackles with or without signs of pleural effusion, or if room air saturation was less than 92%, or there was newly appeared parenchymal infiltration. Certain patients were excluded from the study, especially pregnant patients, congenital immunodeficiency, patients with HIV infection with CD4 less than 200, acute hematological malignancies, neutropenic patients, patients on immunosuppressive drugs within the previous 30 days, including anti-cancer chemotherapy and anti-rejection drugs for organ or bone marrow transplant. Use patients who were on corticosteroids of more than 20 milligram per day of prednisolone or its equivalent for more than 14 days. Patients of COPD with previous history of colonization or infection with Pseudomonas infection, tracheostomized patients, diffuse bronchiectasis or cystic fibrosis patients, patients with aspiration pneumonia, moribund patients or death expected from underlying disease during the current admission, and patient deprived of liberty or under legal protection measures, or participation, or if the patient was already participating in another intervention trial. The primary objective of this trial was to assess the effectiveness of a management strategy combining a broad panel respiratory and multiplex PCR and an algorithm of early antibiotic de-escalation and discontinuation based on both the MPCR results and the procalcitonin as compared to a conventional strategy in severe CAP. The primary endpoint was the number of antibiotic-free days at 28 days, which corresponds to the number of days alive without any antibiotics at day 28. So, when they defined this primary endpoint, the number of days alive without any antibiotic up to day 28 was taken. However, when the patient died within the first 28 days, this number was taken as 0. Coming to the secondary objective, to compare the efficacy and the safety of the intervention strategy and the conventional strategy. So they took multiple secondary outcomes, which was the overall mortality rate at day 28 and 90, organ failures like SOFA score was taken at day 28, cumulative duration of antibiotics. So this was the cumulative number of days of all antibiotics calculated as the sum of duration of each antibiotic from day of enrollment to day 28. Antibiotic exposure was the number of days with at least one antibiotic from day of enrollment to day 28. Resistant bacteria, which was the incidence rate of colonization or infection with MDR organisms or C. diff infection from enrollment day to day 28. Length of stay or duration of ICU stay as well as hospital stay. Quality of life, and then total cost of care at up to day 90. And incremental or decremental cost effectiveness ratio, which was the difference in cost in the composite clinical endpoint of event at day 90. Coming to the randomization was done by the study investigator, which was the ICU physician via an online server. So, it was a centralized blocked randomization, which was done at an allocation ratio of 1:1. It was already prepared by the clinical research unit. The clinicians involved in the patient care were not blinded to the trial group assignment, so it was an open label study. Now, how the patients were included. So, first visit, which was when the patient was taken into the study, which was day 0 and hour 0, it was within 18 hours after ICU admission. So, informed consent of the patient or the next of kin was taken, followed by randomization. Once randomized, demographic and the amnestic data collection was done and clinical examination was done. All biological investigations like procalcitonin and other investigations were sent. Radiological examination of chest X-ray and CT scan was also done. Then microbiological investigations were sent. Now this had to be sent within 8 hours of the inclusion into the study. So 2 blood cultures were sent. Then urine antigen assay for strep pneumonia and Legionella was sent. A respiratory tract sample was taken for gram stain and for cultures. Influenza PCR was also done during the epidemic season. Now, if chlamydia or mycoplasma infection was suspected, then antibody testing and PCR on the respiratory tract sample was done. This was done for both the arms, microbiological investigation. In the intervention 1 arm, additionally, what was done was the respiratory tract sample was sent for broad panel multiplex PCR, Pilmary. So, when the sample was collected, the sample could either be a bronchoalveolar lavage fluid or a tracheal aspirate or a sputum culture also. So, either of the 3 could be sent for the multiplex PCR. Now, if nosocomial pneumonia was suspected during follow-up in such patients in the intervention arm, a new multiplex PCR array could be done. Initial and empiric antibiotic therapy was started within 8 hours according to the CAP guidelines. In the control arm, on the day 0, by the 12th hour, in the control arm, the initial antibiotic regimen was maintained for the first 40 to 72 hours also after inclusion and randomization, unless there was any microbiological indication to change the antibiotic or any conventional report had come up in which some other organism had been detected, and accordingly the antibiotic was changed. If nothing of such sort had been done, they continued the initial antibiotic regimen. So this is a schematic representation of how the research proceeded. So from initial 48 hours, from hospital admission to ICU admission, if it was within 48 hours, it was defined as CAP. So if it was a severe CAP, the patient was admitted to ICU. So from patient admission to ICU referral, it had to be within 18 hours. And then the microbiological investigations had to be sent. Now in the intervention arm, additionally, one multiplex PCR was done. And according to its report, a certain algorithm was used to guide the antibiotic de-escalation. When the patient was recruited initially, empiric antibiotics are started. Now, on basis of this multiplex PCR result, they de-escalated the antibiotics or discontinued the antibiotics in the intervention arm. However, in the control arm, the antibiotics was continued. On day 3, which was R72, at that time, then the procalcitonin values were checked every time, and based on the clinical progress of the patient and the procalcitonin value in both the groups, antibiotic de-escalation was done and evaluated every day. And then on day 28, there was evaluation. The evaluation criteria of the primary outcome was checked on day 28, which was the antibiotic-free days till day 28, and on day 90 was the end of the research. Now, how antibiotic de-escalation or discontinuation was done in the intervention arm is that, now let's say if the intervention arm if the MPCR was positive and conventional microbiological investigation also came or if either came positive, antibiotic continuation was strongly encouraged and narrow spectrum antibiotic was supposed to be given. Now, if suppose MPCR is negative, and conventional microbiological investigation is negative, then PCT value was taken into consideration. If PCT was more than equals to 1, then antibiotic continuation was encouraged and repeat daily PCT measurement was done. However, if PCT value was less than 1, then they saw if the MPCR was negative. If viral panel was negative, then antibiotic discontinuation was encouraged. And if MPCL and virus was positive, then antibiotic discontinuation was strongly encouraged. Now, coming to the control arm, antibiotic therapy was completely at the discretion of ICU physicians. As I had told, in the day 1 and day 2 visits, in the intervention arm, early antibiotic de-escalation or discontinuation was considered based on the microbiological results and the PCT value, as we just discussed in the algorithm in the previous slide. On day 3, which was at 72 hours, in both arms, antibiotic discontinuation was to be considered based on the clinical progress of the patient and PCT value. Now, this is for both the arms. So, coming to the PCT value, if it was less than 0.25, antibiotic discontinuation was strong. Antibiotics were strongly discouraged, means they were supposed to be discontinued. When the PCT value was less than was between 0.25 to 0.5, or there was a decrease of more than 80% from the peak concentration, then antibiotics were again discouraged. If the PCT value was more than 0.5, and the decrease was less than 80% from the peak concentration, then antibiotics were encouraged, means it had to be continued. And if the PCT value was more than equal to 1, then antibiotics were strongly encouraged. From day 4 to day 7, antibiotics for documented infections, if it was supposed to be antibiotic decisions for documented infections were to be taken by the decision was to be taken by the attending physicians. Daily procalcitonin was done. ICU physicians were, however, encouraged to consider antibiotic discontinuation every day according to the clinical evolution and PCT values. However, in all the arms, in both the arms, the recommended maximum duration of antibiotics was 7 days. On day 28, or until patient was discharged, all the primary outcome measures were noted, and day 90, information was collected via phone call. This is just a diagram summarizing how the chronology of research was done. On day 0, when the inclusion was done, informed consent was taken, and in both the groups, history, clinical examination is the usual care group. And in the research group, only the MPCR was done. From day 1 to day 7, everything was done as the usual care. Only the MPCR, if was supposed to be done for patients with nosocomial pneumonia, had to be done for the research. And for the research, they had to note the adverse events. From day 28, everything was usual care except so vital status, evaluation criteria, and adverse events, and everything, and MPCR was read. This was done as a part of research. And day 90, the information taken on phone call was strictly as part of research. Now, coming to the statistical analysis, the sample size was taken from the prorata trial, which was published in the Lancet in 2010, in which the number of days, they thought that the number of days alive without antibiotics was expected to be 11 plus minus 7 days. So, for that, the sample size of 450 patients was required if we needed a power of 80%, and to detect a 2-day gain in the experimental strategy group. So, to have a 2-day gain in the antibiotic-free period, and to have a power of 80% with two-sided alpha of 5%, and 10% taking into account a 10% loss to follow-up, they found the sample size to be 450. Coming to the statistical analysis, SAS version 9.4 statistical software was used. Categorical data was represented with frequencies in percentage, and continuous data was represented with median and IQR. Whenever the data was over dispersed, means the variance was much more than mean. In such over dispersed data, the sensitivity analysis was performed using a generalized linear mixed model with a binomial negative distribution. Coming to the results, the recruitment was stopped in March 2022 before reaching the recruitment target of 450. So the sample size they had calculated was 450. However, the recruitment was stopped in March 2022 because it was decided as such by the sponsors and investigators. It was their decision. Total 406 patients were recruited. The median median time from ICU referral to randomization was 9 hours, and prior or ongoing antibiotics were administered to most patients. About 85% were already on ongoing antibiotics in a median time of 1 day before the enrollment. There was no between group difference was observed in all these things. Now, coming to the results, total of 406 patients were recruited to the study. 21 were excluded because of inconsistent consent and deprived of liberty or protected by law. So, 21 patients got excluded. 385 patients were analyzed. Coming to the allocation, in the intervention group, there were 188 patients, and in the control group, there was 197 patients. Out of 188, only 168 patients received the allocated intervention and 20 patients didn't receive the allocated intervention. And in the control group, all the patients received the allocated intervention. When follow-up was done up to 90 days, there was premature discontinuation because of refusal to pursue or withdrawal of consent or loss to follow-up of about 5 patients in the enrollment group and 7 patients in the premature discontinuation group. So coming to the intention to treat analysis, total 188 patients were considered in the intervention group and 197 patients were considered in the control group. And in the per protocol analysis, total 127 patients were analyzed in the intervention group because 61 patients were excluded from the analysis because 8 patients were wrongly included. 5 patients had a premature discontinuation before day 28, and primary endpoint was not available for 11 patients. And there was major deviation from the algorithm, which was there for the de-escalation in about 47 patients, which is a major drawback in this study. And coming to the control group, 15 patients were excluded from the analysis because 7 patients were wrongly included. 5 patients had premature discontinuation before day 28. Primary endpoint was not available for 8 patients, and however, there was no major deviation. Coming to the results, the baseline characteristics with respect to demographics, comorbidities, prior vaccination status, severity score, vital organ support, steroid use, and management before the enrollment were similar in both the groups. In the group also, the serious adverse events also did not differ between the groups. The primary outcome, which was the number of antibiotic-free days up to day 28, was same in both the group, which was 19 days, and the p-value was not significant in both the intention to treat analysis and the per protocol analysis. Now, when exploratory analysis was done of the primary outcome at day 7, day 14, and day 28 in the intention to treat and per protocol populations, by the day 7, there was a difference of 1 antibiotic-free day in the experimental group as compared to the usual strategy. So there was 1 antibiotic-free day more in the experimental group compared to the usual strategy. However, this difference was not significant when we came to day 14 and day 28, where it was same for both the groups. The same has been represented in the form of box plot. Now, the number of antibiotic-free days at 28 using the binomial negative model also showed that there was no difference between them in both the groups. They also did an analysis of the cumulative duration of antibiotic from enrollment to day 28 in the intention to treat population and the per protocol population analysis, and subpopulation of the patients receiving invasive mechanical ventilation at enrollment according to the assigned study. They found that when the cumulative duration of antibiotics was taken, there was a difference of about 3 days between the experimental group and the usual strategy group in both the intention to treat analysis and per protocol analysis. And there was a difference of treatment of about 9 cumulative duration of, when the cumulative duration of antibiotics differed by about 9 days in between the experimental group and the usual strategy group in the mechanical ventilation patients. Coming to the secondary outcomes, all the secondary outcomes were more or less same in both the groups, except the cumulative duration of antibiotics, which had differed by about 3 days in from the between the experimental group and the usual strategy group. So the cumulative duration of antibiotic was 3 days less in the experimental group. Now, the post-hoc analysis, when it was done on the antibiotic-free days and exposure and cumulative duration of antibiotics, in according to the bacterial documentation and regardless of the assigned strategy, they found that in taking into account both the groups together, total 80 patients had at least one bacterial documentation of Staph aureus, Legionella, and Pseudomonas. And 305 patients did not have any bacterial documentation of these three organisms. Why it was considered? Because in these three organisms, the duration of antibiotic prescription was about 10 to 14 days, which was longer than what is usually prescribed for Haemophilus influenzae or strep pneumonia, which is around 5 to 7 days. Now, so in these patients, the duration of antibiotics was more. So the duration of the number of antibiotic-free days were lesser compared to those patients who did not have documentation of these three bacteria. Now, coming to discussion, the combined approach till 28 days did not reduce the antibiotic exposure. It did not improve the clinical success. However, it had a 3-day shorter cumulative antibiotic duration and 1-day shorter cumulative narrow spectrum beta lactam use. So the advantage came in the total cumulative antibiotic duration. When conventional testing was done, the bacterial detection rate was about 52%. But when conventional testing was added with the multiplex PCR, the bacterial detection rate increased to 78%. So this shows that that MPCR increases the sensitivity, at least and bacterial detection rate in patients with community-acquired pneumonia. In this study, what we found is that up to day 7, there was one more antibiotic-free day in the intervention group. However, when the analysis was done up to 28 days, there was no difference in the antibiotic-free days in both the group. Now, why it happened is because the total number of patients who had Staph aureus infection, Legionella infection, or Pseudomonas infection was almost 3 times more in the intervention group as compared to the control group. And according to the antibiotic guidelines that these hospitals were following, the duration of antibiotic therapy for these organisms were up to 14 days. So the longer duration of therapy was going on for these patients. And since these patients were 3 times more in the intervention group as compared to the control group, by day 20, so they needed more days of antibiotic therapy. So this one antibiotic free day difference that was created in the intervention group kind of got neutralized when the analysis was done up to 28 days. Now, there were certain strengths of this algorithm in the intervention group that they had taken. It was a pretty straightforward algorithm to follow, which made the decision-making process easier. It encouraged prompt de-escalation of antibiotics, and so that more pathogen-directed therapy could be used. The adherence was good and uniform. About 75% patients were adhering to the algorithm, which was dictated for this antibiotic de-escalation. And it was also seen that in patients in which the multiplex PCR was positive, in such patients the adherence was more, 80%, than in MPCR negative patients, in the patients in which they didn't detect anything in the PCR, which shows that in general physicians have a predilection of giving antibiotics per se and have a resistance towards de-escalating antibiotics even when there is a bacterial evidence of no infection. So primary outcome, other than that, the primary outcome that was chosen in this trial was number of antibiotic-free days till day 28. And in the so it considered both the prognostic factor and the antibiotic exposure days also. So if patient had expired or was not alive by day 28, then this antibiotic-free days was taken as 0. So that considered the part of the prognosis. And when total antibiotic exposure was taken, then the duration and antibiotic free days was taken. So however, in other other studies which had been done prior, they had taken the total duration of antibiotic exposure or time taken for antibiotic modification or changes or de-escalation as the primary outcome. But this primary outcome that they had chosen considered both prognosis and the antibiotic exposure. Coming to the limitations of the study, the algorithm didn't account for the bacterial quantification, as in how much copies per ml was there in the MPCR testing. So usually when in the BAL, which we do, if the significant amount of colonies are there, then only that should be taken into consideration or not. Because procalcitonin was used to guide the antibiotic discontinuation after day 3 in both groups, and it was combined with a recommended maximum duration of antibiotics of about 7 days, it could have contributed to minimize the difference between the groups, because they have given a limit of maximum duration of antibiotics of 7 days in patients, or if they have and they were using procalcitonin in both the groups to guide the antibiotic discontinuation, so the difference might have minimized because of that. And they were using longer duration of antibiotics for Staph aureus and Pseudomonas, and more such patients were there in the intervention group. That could have limited the number of that could have affected the results. And only immunocompetent patients were included. Usually, immunocompetent patients have less MDR organisms. MPCR can be more useful in immunocompromised patients who have a predisposition to more MDR organisms. In them, MPCR is more useful to us. The sample size was also not reached. The sample size which was decided was 450. However, the study was stopped when 406 patients was recruited. So the study might be underpowered. Other than that, MPCR was used on sputum sample as well, which is not an ideal sample for doing an MPCR, a multiplex PCR. Coming to the strength, after randomization, the patient had balanced baseline characteristics at the time of randomization. However, the patients with Pseudomonas staph Legionella infection are more in the intervention group. This was not known at the time of randomization. This came to account when the conventional or MPCR results came. It included a large sample of patients, about 406 patients. So whatever difference was, if it would have been detected, it would have been clinically meaningful. And it was conducted in ICUs at multiple sites. So 20 ICUs were taken and broad patient population. So there is definite generalizability in the results. So to conclude, we can say that combining a broad spectrum respiratory MPCR and procalcitonin to guide antibiotic de-escalation or discontinuation in ICU patients with CAP failed to reduce the antibiotic exposure and improvement outcome on day 28 compared to the usual strategy. However, it may be associated with early antibiotic saving and a reduction in the cumulative antibiotic duration on day 28. Coming to the critical appraisal, the research question was relevant, the study design was appropriate for the research question, and the participant assignment was properly randomized. The methodology, the trial protocol and statistical analysis plan was published before the conclusion of enrollment. The status of blinding and allocation concealment was done. The allocation concealment was done, but the blinding patient were not blinded. It was not possible because the MPCR results had to be taken into consideration for de-escalation. So blinding was not possible in this study. The funding agents were not involved in the design or conduct of the study. The baseline characteristics were similar in both the groups. However, the patients with Pseudomonas staph and Legionella infections were more in the intervention group. If the adherence was around 75 to 75%, so there could be any possible bias. Both the groups received the same level of care. The sample size estimation and power calculation was mentioned. The statistical tests were mentioned. Outcome measures were properly defined and confidence intervals were reported. And whenever the dropout or missing data was present, it was quite substantial, about 25%. The study limitations were discussed. And this study, the results can be applicable to the local population as we can use them in our ICUs. Thank you. And thank you very much.
Thank you, Pallavi, for your excellent presentation. Just to add, you have summarized the limitations also nicely,
Yes,
and just a few things to emphasize. The first thing is that whether the result of the study can be extrapolated to our scenario where the drug-resistant organisms is so prevalent even in patients with community-acquired infection that needs to be taken care of. Number one. Secondly, the study did not complete its recruitment. It was planned to recruit 450 patients and it was prematurely stopped at 400, around 400. Why it was done, it was not very clear. And role of the sponsors was also, I don't think so. It was whether they had any involvement in the plan of data analysis was there or not. That is, I think they have not mentioned. I'm not sure. And
So they have
thirdly,
mentioned that they are not involved. They were not involved in the
okay,
design
then
or publication or analysis.
analysis. Okay, then it's good. But there may be some problem with the randomization technique that you have highlighted that Pseudomonas, Staph, and Legionella are more in the intervention group that might have affected the outcome. Yes, it is true. But in that case, they could have done a subgroup analysis and a test of interaction they could have reported, which they have not done. Though they have found difference in the some secondary outcomes, so utility of these outcome is probably limited, not much. And this test of interaction and the subgroup analysis would have been interesting to look into whether what happened to the patients who did not have a Staph aureus, Legionella, or Pseudomonas infection. So that was not reported. Otherwise, the study definitely holds value in critical care practices. This is just I want to add. Dr. Jitendra, please.
Yeah. Thank you, Dr. Pallavi, for excellent presentation.
Thank you, sir.
This study, if we go our usual general club, this is a little bit different from the what we are doing in the general club. Why it is important? What is the difference for this? Most of the time we select a very good quality paper, and somehow here the quality of paper is a little bit compromised, and that's where the our trainees exercise comes into the play, the critical appraisal of this thing, because most of the time those study were the landmark study, all the points or checklist of your critical appraisal will take into your favorable way. That's why they are landmark and the practice changing over there. So here there are the certain things which is a major, I'll not say flaw, but a major concept disruption over there. So first and foremost, when they analyze, could you make out what is the first and foremost the analysis level? The disruption is intention to treat. If you show us a study flow diagram, which is how many recruited and all those things. When you see the carefully about the typical definition of intention to treat is the all should be analyzed after randomization, not after the selection of certain exclusion out there. So that is the first and foremost a kind of, and when you see the paper, author failed to this explain. They said we selected 406 patient and the intention to treat was applied into 385. Whereas the ITT is clearly said after randomization, everything has to be analyzed. So that is the one point, that is the you can say a major or basic principle of the intention to treat. Otherwise, there is a little bit what we can in a simple word we can say modified the intention to analysis. Otherwise, it is a little bit disruption of the conventional or way to. Otherwise, it would be a per protocol analysis. And definitely the intervention group is not true representative characteristics or the significant number actually dropped out from the discontinuation. That is the you already emphasized the 47 numbers.
Yes.
Third thing, what is your understanding? It's not a right or wrong any answer, just your understanding. This study can completely close our hypothesis or the question over there, Our research question, this is sufficient enough to
Definitely
close?
not, sir.
Definitely not. So what
Yes,
is the reason why we say it can't be?
so first of all, sir, the discussed sample size was not reached. There was a prior stop cessation of the study before reaching the sample size. So it is underpowered. So power of 80% was not achieved, first of all. Other thing is there was major deviation from the uh, algorithm that was set up for the de-escalation. That was There was a major deviation. Also, it was seen that the deviation is less when the adherence is more if the MPCR value is positive. Let's say if they have found some organism, then they are adhering it to it. If they have not found the organism, that is when the main role comes to de-escalate. So if you have not found the organism, that is when you should de-escalate. That is when the role of the MPCR is coming, in addition to whatever clinical judgment or PCT value or the lab values that we have. So that was as we had discussed, it was only 61% in the patient in which the MPCR was negative. Just come to
So
that patient.
nutshell, these are the points based upon we can say this is not the good quality of the research.
Yes, sir.
That's the bottom line.
Yes, sir.
Okay, I give you one scenario. Whatever you find, there are little bit points based upon we make. One thing should be very clear. Good quality doesn't mean the wrong conclusion. By chance, you can get the right conclusion also. So that's a different issue. Now, those points which make this research little bit inferior quality, and I give you a hypothetical situation where everything is the perfect picture. All the this thing, whatever we are seeing, everything is perfect. Maybe you achieve your target population with little bit more than that, whatever they want, 80% of this thing and 5% of the correction, everything. And all these things is theoretically suppose, and we get the conclusion of there is no difference. In that scenario, still you close the matter. This is a very basic, nothing related to directly this paper. Then I'll come to, because most of the time, especially when we are beginner in the intensive care student, we don't understand why there is so much study keep on coming. Then when already said, say for example, in the ARDS, there is no mortality benefit of steroid. Then why are these papers keep on coming up? So can you
So
little
the
bit
study
whatever you
population, sir.
understand then?
Yes, sir. My understanding is that in patients in France, the patient who are coming from community, the pattern of resistance pattern of the organisms is very different. They don't have much of MRSA. They will
No,
not have
I am not
much.
questioning the generalizability. I'm just
Okay,
on
sir.
the research language.
Mm, so I'm
So
not
I'll tell
able
you why.
to. Yeah,
Why?
okay, sir.
Because all are these research are based upon the alternative hypothesis. So all your sample calculation and everything was done by the reduction of the antibiotic exposure or more free days of the antibiotic in the live patient. That was your a primary endpoint based upon you did the your sample calculation. If you really get the answer for this alternative hypothesis, then the system is closed because you begin with that. So your everything is powered in that way, and you get the result. But your study is not powered for the negative equal. That is the null hypothesis reaching. But you actually calculate. You means the investigator. They calculated based upon the alternative hypothesis. If this could have achieved, then it closed the our research question in that particular situation. I'm not talking about the clinical relevance over there. Whatever they selected their subset and all this, and then they will close it. But when you start with the alternative hypothesis and you land up with the no difference or negative outcome or null hypothesis, despite the good quality of your research, still the question will remain open. That's why you still seeing the paper keep on coming over there, because they started with this thing, and most of that study is not designed for the negative outcome, because when you go for the null hypothesis, you require a very large number of the population. If you design from the null hypothesis, then it's okay. Then your conclusion would be perfect in the sense of the answering the your research question. I think that is the most suitable way. What do you say, Dr. Sun?
Definitely.
Yeah.
Research question, what was tried to be answered by the research team, the original question, whether it actually reduces the days of antibiotic therapy in these group of patients, like CAP patients requiring critical intensive care. That definitely that as you were correctly pointed out. So the alternative hypothesis was alternative hypothesis was rejected. So with the current scenario, and it was rightly said, okay, from the research design, it's okay, but definitely, I also agree with you that the scope of further researches are there, and even if the researchers have found some difference, say for a hypothetical example, they have difference and they have concluded that the duration of antibiotic therapy with the standard protocol comes down. So then also it needs to be taken care of with the possibility of false positivity. That also needs to be taken care of, and which group of patients are benefited maximally. So in the days of precision medicine, where we are already thinking that intensive care is all about the heterogeneity. So interpretation of randomized control trial, particularly a negative one, so-called negative study. So I don't believe whether anything is a negative study. It's just the study failed to reject the alternative hypothesis. That's it. There's nothing called a negative study. So in this scenario, the heterogeneity, I'm more interested to know about because I believe the populations with staph and related infections is little different from a Haemophilus influenzae or streptopneumonia. So this question needs to be answered apart from what you have already mentioned, the other limitations of the study, and you are correctly mentioned that definitely it's not a very good quality study, like a practice changing trial, or a trial which changes the our thought process about community acquired pneumonia. Is definitely not like that. I agree to that, and more importantly, we have to think about the microbiological pattern of the disease, the baseline disease severity, and more importantly, the different geographical location. So definitely, the chapter is not closed. A huge number of researchers probably required. Yes.
So yeah, our most of the young colleague actually see the general club. So again, whenever we go for the any study coming and try to apply in our clinical practice, so clear cut two major steps. Whatever we do a critical appraisal, that is the one aspect, whether you believe in the certain hypothesis they made it or not. Just you believe it or not. Once you believe, now this your belief is going to applicable in your patients or not. That is the second aspect. There may be a good excellent quality of the paper and they succeed in the answering of the research question, but your clinical a patient population is not matching for that. There would be a problem in the generalizability, not the research. That's what I wanted to convey,
Absolutely.
because most of
Absolutely.
the study coming on the
Absolutely.
just small thing, because most of the time we use, otherwise you described very well. That's why I'm not going into the details of the paper, and because method you very well explained, the way they analyze, they very well explained. But if you read the paper carefully, here the a language, a control over there. I'm not skeptical and criticizing, but you keenly read the paper, then it comes to our author is a very smart. Whatever their limitation with, they use the language so that it would be concealed over the limitation over there. When you You read and you are able to understand this thing is. What is the difference between post-hoc, just like in this particular research, they make a post-hoc analysis of invasive ventilation. And obviously there would be a subgroup analysis. So can you tell us our audience, they are the very young training intensivist, what is the difference between post-hoc analysis and the subgroup? Why can't we say it was a subgroup analysis of the invasive?
So as far as I understand, post-hoc analysis, the patient population remains the same in that a different time duration is taken. Let's say the outcome is divided in different time durations, then that is post-hoc analysis. But subgroup analysis of the patient population itself is changed. So that is subgroup. This is my understanding, but I would like to know more.
In a simplified way, because these are the terms keep on coming. That's why when you are designing your study, still you are design in the stage of the designing of your study, and you set the rules for the subgroup. Whatever you analyze as a primary outcome, apart from that, every would be your subgroup analysis or secondary. This thing is because the primary would be your sample calculation, all this. So before starting the game, if you set the certain rules, I will going to analyze in this way, in this particular points. It may be time, it may not be a time. Then it would be a subgroup analysis. I'm clear?
Yes.
Now, you conducted the research. Once you did the research and you see there is some pattern are making over there, which right from beginning you didn't make the rule, but once all the results comes into your analysis stage, then you see there's certain pattern you are looking over there. Say for example, you see I'm getting some signals if vasopressin is used, and then this thing is because initially you didn't make the rule for that. If there certain pattern is you find it and analyze statistically, that would be a post hoc analysis. So if you read the carefully over there, they didn't make they will going to analyze whether the invasive ventilation made in patient was the invasive ventilation or not, the duration. They didn't make this thing is from the secondary outcome. That's why the second, but once they completed the research and they found the certain pattern is emerging, if you take this thing in account, that would be a post hoc.
Just one thing I need to add regarding the subgroup analysis. So subgroup analysis in randomized control trial is a highly debated area because the subgroup analysis finding, whether it is a positive or negative, there are high probability there because of chance, even a positive finding, number one. And secondly, if someone is reporting a subgroup analysis, it has to be reported with a test of interaction, which has not been done in this study. This is a standard recommendation, standard statistical recommendation. Number three, yes, subgroup analysis are not junk, particularly if you have used a stratified randomization, like the patients who are on invasive mechanical versus who are not on invasive mechanical ventilation at the time of randomization. They could have done it. So these two group of patients, probably they have a different severity of illness expected to be. So the duration of antibiotic therapy will not be similar in these two group of patients, and our therapy which we are testing, our hypothesis may be more effective or less effective in any one group of patients. So if there is a strong biological rationale to think about it, so it is better to use a stratified randomization, which gives you a better statistical power to the subgroup analysis, number one. Secondly, this is on the negative side. On the flip side, yes, subgroup analysis gives an at least some idea that whether there is a heterogeneity in the treatment effect. So treatment effect may not be homogeneous across the population. It gives us an idea. If it's not a predefined subgroup analysis, it gives an idea, as Dr. JEETENDRA said, that okay, the treatment may be that we are getting some signal. The treatment may be affected in a particular group, which we can identify, and further randomized control trial can be designed on that particular group of therapy with a reasonable amount of sample size that can be derived from this present study. So subgroup analysis, yes, definitely they have a role, but you have to take the result with a pinch of salt to apply in a clinical practice. So it's not definitely it has a role, but you have to think about it how you are going to apply it.
Okay, sir.
I think that's all from my side. Nothing. What we make a conclusive remark for the study. There are so many study comes in your practice, which might increase your understanding, maybe thought provoking. Doesn't mean every study you will keep on your changing the clinical practice routinely. Individually and some certain situation you can consider the information which you obtained from the different studies over there. And clinical relevance, most of the time we believe in the good quality statistics, but not all the time. Sometimes excellent clinical answer can be given even by the retrospective trials also. So that's why we bifurcate over there. Once we see the quality of research, then we all the time concentrate towards the just a research language and the quality of the research. So that, and what do you mean by the quality of research? Whatever they say, you believe it is truth in the universe. That's the simplistic way to express that. Even a bad quality research can give the correct answer also. The question is whether you believe it or not. Based upon these are the things, you can hit the target by chance also, that, but it won't give you a scientific way to believe. That's why we all the time analyze the study, critical appraisal, and finally then from there they comes into the clinical practice. So the conclusive remark here is how this study and the when we spend so many man hours, man means in general, of course, women and men hours to discuss this trial, and you prepared also. So how it is going to help? It is going to help you just increase the understanding of, you can further research plan this way. You can think in clinical practice in this way also. Whether you believe in the result or not, what is difference between believing in the result? Once you believe, then you started practicing routinely. If you don't believe and you are little bit agreeing principle wise, then occasionally you use completely or partially in your, or even you don't use it, then still it gives you a thought provoking and may help for the further research. So I think that's any final conclusive, Dr. Souvik, then we can close it.
No, sir. You have already given the final conclusion. So we'd like to see further researches regarding this area. This is an interesting area where we actively search for a strategy which could reduce the antibiotic use in our intensive care practice. So definitely it's an area which worth looking, and I wish some data comes from India also, so that we can change our practice or adopt those strategies in our routine practice. That's it. Thank you, sir.
Thank you,
Thank you,
Dr.
sir.
Thank you.
Thank you,
Thank
sir.
you.
Okay, good night.
Good night. Thank you.